validation and support for autistic people and their loved ones. Now, I know what you're thinking. Huh? A video on suicide? That sounds depressing or down. In my opinion, this is one of the more fascinating, empowering conversations I've ever had. Fact is, autistic people experience suicidal ideation, thoughts, or suicide at disproportionately high rates compared to our neurotypical peers. So having empowering conversations around this is going to be beneficial. And my guest, Jesse Shears, does just that. He's a lived experience practitioner from Life Connect, an Aussie-based organisation with a lived experience suicide awareness program that equips people with skills that make it easier to have conversations around suicide. Jesse, my friend, thank you so much for being here. Welcome.
Thanks, Orion. It's really good to come on.
I just want to start at the start because it's great to connect, and you reached out, and I think that's the best way of starting this. So rather than in my words, what is it that you're all about? So Life Connect, and what is it, in fact, that you do?
There's kind of two parts of it. Like how I came to the work is through the lived experience angle, and I work like Life Connect is a branch of a national company called NEMI, which is a mental health organisation. So they have a lived experience workforce, and I came in through that way. Not specifically autism, but they are drawing on a whole bunch of different people's experiences. So that's really great. But yeah, at Life Connect, we do suicide awareness or prevention training. We are never sure which word to really use actually. But so that kind of looks like us going into a whole bunch of different settings. So it's community groups. Often we're with, clinical mental health workers or support workers as well. And the thing that, really sets us apart in doing these trainings is the lived experience angle that we bring. So we have people on the team and lived experience around suicidality, I should say. So, there's people on the team who have been suicidal, have cared for someone who is suicidal, are bereaved by suicide. And, we kind of compile and work together with those experiences to inform the trainings that we do, because there's often a little bit of a lag between research and lived experience and all that, or like vice versa as well. So we're trying to stay up to date and as current as possible with the thinking that's kind of going on.
You're preaching to the converted really here, aren't you, mate?
Yeah, I know. Yeah.
I mean, lived. Tell us more about you. What's your story?
Yeah, had a whole lot of struggles with pretty intense anxiety and struggles to connect and feel accepted in the world and stuff. And only about a year and a bit ago, I got diagnosed with autism after meeting my partner, who is autistic. She was the one who went, "Hey, have you ever thought about like this angle that you might have been missing, or everyone might have been missing?" So, and it was just a huge revelation in that way. It was a real life-changing moment. Difficult, but life-changing in what's turned into a really positive way that I can use these experiences that I've had to talk to groups of people every day about mental health challenges, autism, suicide, and all that kind of stuff.
Does it blow your mind that the story is so similar? Like when you, like me, you, other adults talk to, this lost generation, I swear, man, like this lost generation we're a part of. It's like out of nowhere we've started to form, and we're becoming like this really, really amazing support group for each other. But it just shows how far behind the medical world was. I mean, so presumably you feel like a lost generation, like me, like the people I talk to.
Yeah, definitely, and it is. I mean, that's what's great about like coming across your podcast and all these other different resources. Because I was 28, when I got diagnosed. And it is a weird, lonely experience, I think, for some people. Everything's for some people, isn't it? Like, there's always that caveat. But, it was a really intense kind of grief-stricken, more looking back at life and that feeling of like, oh, something was missed here or lost, or I was a bit overlooked. In that way. So it's one of those things where, out of all that has come like I get to do this amazing work where I'm hopefully helping people, support people who are suicidal, and, you know, bringing all of this stuff. I try and look at it now as, you know, try and see the good that's come out of these really hard experiences as well and grow from that. But
that brings up something, a thought in my head, man, because I want to pick your brains on the specific kind of story and stats of neurodivergent people and mental illness and depression and suicide. But before we do that, this really fascinates me. What do you put down to not being diagnosed, but living as an undiagnosed autistic kid, leading to your anxiety, leading to the things you went through? I mean, sometimes you look back and think maybe if you were diagnosed as a child and had supports or more acceptance, this would have helped. I mean, do you know what I mean? It's like a chicken and an egg thing, but I find that fascinating.
It is really interesting. I had to do a lot of, because when I first got diagnosed, there was grief and there was anger and all of this kind of thing that kind of came up for me, which is also, I've, you know, read a lot of articles and things that's a pretty common experience. Not everybody's
100%.
experience, but it can be. Yeah, it is really tricky to distinguish that in some ways. I was talking to one of my co-workers is autistic. I don't think she'd mind me saying, like, nobody's going to know anyway, but and she got diagnosed when she was quite young, like 7 or something, let's say. And she had a really hard time being diagnosed in the 90s when there was probably even less, you know, understanding, awareness, all that kind of stuff going on, and probably more bullying and all of these kinds of things. So it is a little bit of like a mental game I've played, is like, there's this wish that it had have happened, this diagnosis. I'm not sure whether that would have made things better back then or not as well, but I've tried to go, you know, it is what it is.
Yeah.
I have an opportunity now to kind of like, you know, use the diagnosis and everything to really, tap into who I am and just be myself as much as I'm aware of as well. But it's a tricky balance. Because you got diagnosed later, didn't you?
Yeah, well, that's right. Yeah. So it was my son who was having a kid. So basically,
that's right.
Like a lot of people in our kind of ballpark, you know, it's a kid that triggers it, and that's what's so interesting about it. But and that's the thing, right? So, you know, the diagnosis was obviously autism, but also a couple of types of anxiety.
Yeah,
and you know, sometimes I kind of argue with myself that, well, maybe that's just autism. I have these little arguments with philosophical arguments with myself. But this is what I want to talk about, because I did a video recently about mental illnesses and all the different connections and things. And there was something that I never really knew before. I learned something new myself when it talked about the propensity for autistic people and neurodivergent people to have certain conditions. And one was obviously a self-harm, but also I think it was referred to as like suicidal ideation. And maybe we should define some terms here for people, because actually, from what I remember, what I realised, that actually meant the idea of thinking about it, but not actually doing it or trying to do it, the actual physical side of it. So like, for our discussion going forward, because I want to talk about it, the kind of the neurodivergent community specifically, but for our discussion going forward, can you help us out with just defining different things like the type of things you deal with? Because clearly you're helping people who have potentially tried to do something physically, who think about it, who know people. Am I right in saying that?
Yeah, so we do a little bit, like, it's the difficult one because we do it with whatever group kind of comes to us or we've reached out to. So, but the thing that we find is generally within every room that we're in, there's a lived experience of suicide somewhere. So we really try and be mindful of that as well and use, trauma-informed practice in that way.
This is what's confusing me though, Jesse. How can you have a lived experience of suicide? Wouldn't you be dead? This is what I'm sorry to ask a stupid question.
No.
This is what I'm saying to define it for the audience. Do you understand how an autistic person could take that the wrong way?
Yes,
you
definitely.
can't. Lived experience of suicide is, well, you're going to have to come and dig me up, basically. Do you see what I'm saying?
Yeah,
So
sure.
when you say a lived experience of suicide as that person, you mean an attempt, basically, a failed attempt. Is that, or it was stopped? Or so again, I'm not putting words in your mouth. I'm saying, please help me work this out.
So we really define the lived experience aspect of it as, we'll say our team has a lived experience of suicide. So really that includes suicidal thoughts or ideation, which is, essentially the same thing. Someone who has lost a loved one or someone they care about to suicide, so being bereaved by suicide. Yeah, I think those are the kind of categories that we're working with in our team. There are other things that might come up that are, suicide is very complex as well, and people might, be in these different camps of lived experience or have some experience over here and some experience over there. The idea is that thoughts and attempts, we're a service that's really trying to, I guess, destigmatize and normalize how the body and, the physiological systems that we have, like why suicidal thoughts might happen for somebody as well. Yeah, we're trying to put an emphasis on that, I guess, like normalizing that when we have thoughts of suicide, they are very distressing and they can be a really, they are a kind of a scary thing for a lot of people and a lot of loved ones as well. But we're trying to, get across the message that it's a normal response our brain is throwing up to these really difficult circumstances that we're in.
Yeah. And then, like, you're talking about normalising it. I mean, you've obviously come to the right place. You know how I talk. Yeah. I mean, from my point of view, I didn't realise it was, something that was weird. Like, I mean, do I think of the idea of, like, do I have to keep living each day? Probably. Before my diagnosis and during my diagnostic period, which is bloody horrible, and like you get crappy doctors, and I mean, my wife said she totally was like fearful for me, and I was absolutely like suicidal, because my mind says, mate, what's the point? I mean, like, if the doctors are saying there's nothing wrong with you, you're just shit, you're just bad, you're just a crap person, and I know from living as an undiagnosed autistic person, if I'm not autistic, I am just a bad person, I am just crap. It doesn't even occur to me that it's illogical that I would just rather be dead. And now, I'm not trying to encourage people to do it. I'm telling you want to normalise it. I'm telling you what's happening up here. Yeah. Like, life's hard, man. It's tiring and hard, and I'm over it. Like, that's not going to go away. It doesn't go away. Like, that's how my mind works.
No, and that's right. People live with suicidal thoughts for their whole life as well. And that's the part that we're trying to say, you're not broken or bad for having these thoughts. Like, it's not like you're abandoning everybody in your life. Like, this is a normal process that our brains throw up as essentially an option when you're saying, I don't feel like I can do this anymore. Or your brain's like, we got a solution over here if you want. It's like, it's actually, like, I've heard people talk about it as it's almost like a comfort, or it's like, it's there if I need it. Like, it actually can be a factor that keeps them going for another day, having a suicidal thought, which seems, so counterintuitive. But these people are saying, that just that it's there, like that, it's almost like a security blanket or something. And
from that, you keep saying your brain, your mind. Now, we know autistic people, neurodivergent people have a different brain.
Yes.
So this is where I guess let's focus on neurodivergent people, autistic.
Absolutely, yeah.
And I just want to say, for starters, regardless if you are a neurotypical person, an autistic person, if you're neither neurotypical nor autistic, whoever you are, I value you. Your life is valuable, and if this conversation at any point, wherever you are on the planet, makes you feel something, and you need to talk to your safe people or to someone. All I would encourage, because we're not broadcasting to one country, all I would encourage is you find a support organisation in your country online and use their chat rooms or use their phone numbers and reach out to someone. I would recommend that at any point. But now let's focus on autistic people or neurodivergent people. So we have a different mind. Does that mean, because I'm sure the stats, and there was that Senate report in Australia a couple of years ago, I'm sure the stats for suicide and mental health was off the charts, disproportionate, for autistic people compared to neurotypical peers. Is that right?
Yeah. So to contextualize it a little bit, it's a really difficult one to find research on, and I kind of think that's part of the challenge or whatever that we're facing as autistic people, is that the data's telling us across the world that autistic people are, it's usually around 6 to 9% more likely than general population, so that's how these things are always quantified or reported or whatever. It varies a bit, but there is a pretty dire lack of research around it as well for such a group that has such high rates of suicide. Usually these groups that have higher rates, they'll get the research and funding and that kind of stuff. Whether that works or not, that's a different story. But, there hasn't been a heck of a lot of emphasis put on autistic people as a group that has these higher rates. And hence there's not a lot of research and funding happening for that at the moment. But in saying all of that, there are these little studies that have been happening and like meta data analysis as well, which is a good way to kind of gather a big bunch of information. But, there's reports of 36% of people who are autistic have a suicide attempt in their life, which is, it's hard because it's always compared to general population, but that's a really high number compared to what we see in a lot of groups. Like these are significant numbers. The other thing that we see, and I think this is an interesting thing as well around why autistic people might have high rates of suicide, because that's always the interesting thing for me, is these stats come out and what's the story behind it essentially. What does this mean? And when I was researching all of this, the one that jumped out to me was suicide's kind of seen in general as a man's issue as well. Like in it's kind of one of the myths around it, like men, stoic, silent, but then they take their life kind of thing and nobody sees it coming, is like an old stereotype. And there's some truth in that. Men do take their lives at higher rates, but essentially like suicide's not discriminating in that way. It's, it can affect anybody. But what's really interesting is in autistic people, essentially those rates are reversed. So women are actually taking their lives at much higher rates than autistic men as well, which I think, to me probably speaks to the late diagnosis, high masking, all of this kind of stuff as well, which I think is an interesting or an important kind of statistic to look at, I think, as well.
It's more acceptable, I think, for guys to be autistic.
Absolutely.
Honestly.
Yeah, definitely.
Like with, like the demands placed on motherhood, right? And women are more social butterflies or whatever you want to call it, blah blah blah. It's all crap. But what I honestly think one of the main things is because people just accept guys being autistic more than women. In fact, as you well know, that's another kind of myth. The idea that you can only be autistic if you're a white boy, basically. And as you say, it doesn't discriminate gender, it doesn't discriminate race or age. So that's a really fascinating. But you know what's crazy though is it's not like 36% of autistic people, but it's not like we have on par percentage. Like we're a tiny fraction of the overall general population.
Yeah, so there's statistics around that as well. I think that I saw one. This was from the UK. I think this is from Autistica in the UK, but they were saying 10% of the suicides that they had looked into were autistic people, when the rates of autism in the UK is around 2% of the population. So it is disproportionate in that way. Yeah. And
that's bad. That's bad.
Oh, yeah, it's very bad. But yeah, I think there's, in my mind, like suicide is a response our systems throw up to distress as well. So when we look at autistic people, we know there's higher levels of distress from all the things I know you talk about on here with the sensory challenges, the masking, all of the things that Orion's, I'm sure, already gone into a lot. Yeah, those distress levels is really what I see as something that is not really being addressed or looked into too heavily as well in research.
What's fascinating, the point you just made. See, the world will tell me that only mentally ill people would have suicidal thoughts when they're stressed. And you're saying it's, in effect, a natural response. That's different to what the narrative would tell me.
Absolutely. Yeah, there's a few myths that we actually usually start our training programs with a bit of myth busting and things.
I'd love to hear them. Yeah.
So one is what you just said, where so that is the common myth is that it's only people with mental health issues that take their own life, and probably more specifically like major depressive disorder or something like that as well. We know that that's just essentially not true. More often than not, suicide, or like a really common reason for suicide is a relationship ending, or, you know, these kinds of what I'd call big life events or big life stresses are actually probably almost just as common as it being from a diagnosable mental illness. So yeah, I think it's a lot more, it can be a lot more situational and like environmental than I think people realize. And again, I think we see that in the autistic community as well, where it's, you know, it could be severe burnouts or all these kinds of things that come up that that can cause,
because you realize yourself, autistic people feel judged enough, right? The last thing you need to do is start telling people additional stuff like we're having suicidal thoughts, so they can judge us further.
Yep.
And put more barriers and you know, badges on us. Like, what do you say to autistic people that in that exact position? Like, they're autistic, their life is hard enough, as you say, they've got all the things to navigate. That, you know, they have these types of challenges. They clearly probably would benefit and want some sort of assistance and help, like from yourself. But they think, well, if I flag this, like I'm, you know, just another thing for people to judge me by. Like, you must relate to that. But what do you say to them?
Yeah, it's a really tricky space, and that's kind of part of the work that we're doing is literally just that, and what you're doing in this, you know, the neurodivergent community as well, is that breaking down the stigma and these myths and that kind of thing. I think there's a lot of, I think with suicide, and I see this relating to neurodivergent communities, but just generally as well, is there is also a lot of fear from the person who might be in the support role or carer role or that kind of thing. Like, it's kind of a bit of a taboo topic. It is a difficult thing to talk about it, particularly when, you know, you might have emotional investment in a person as well. There can be a real feeling of responsibility, you know, for that person's life or their suicidality, like trying to stop that happening, which is often not the most helpful way to deal with anybody who's in any kind of distress, I guess. So that's another thing that we like to try and do, is for people to kind of have a look at what comes up. If somebody was to come to you and be like, I'm feeling suicidal, you know, and this would, you know, it might be in a family dynamic. So there is a lot of emotional investment there. What would you, like, what do you feel? And is there fear there? Is there these barriers that you have to overcome? And really, we just ask people to tap into their values, essentially. Like, you care about this person, you want to help. Your fear is probably because you care about them so much as well. So these responses that we have that might seem dismissive or something, or an overreaction, let's say, to someone being suicidal, like, let's just get you to the emergency room or whatever, like straight away. When you can sit and connect and kind of share that pain that somebody's bringing to you, because they're really just coming and saying, I'm in pain or I'm in distress and I don't know what to do about it. I want it to end. You know, we can sit there and really, you know, connect over empathy and that kind of thing, where we can alleviate some of that pressure they're feeling in that moment as well.
That's such a distinction, though, and this is something I want you to keep talking about this, because, and I'll tell you what I mean. So here's the distinction: it's an emergency, or it's a natural response you can navigate your way through. Right?
Yeah,
they're two very big distinctions.
Yeah.
Now let's assume that the majority of people, if their child or someone, you know, brought them the news that they feel suicidal, for me, the natural response would be, well, it is an emergency because this is my kid. I love him. Get him fixed. I want to get him fixed, right?
Yeah.
Get him on meds or whatever.
Yeah.
By the way, I take medicine for anxiety, so I'm not saying people shouldn't take medicine.
No,
it's right
same
for them.
here.
I'm just saying it's not the first thing. I also see a psychologist and try to do physical exercise and do things that bring me joy. Can you broaden on that? I love this idea. So, and I mean, like, you know, when you're talking to parents, carers, people, because this is not just about autistic people, but can you broaden a bit more on that distinction, and also,
sure,
I guess, walk us through the difference between racing off to ED? What's the other option, and how does that look?
I think for me, it's really about, we still want to hold space for the autonomy of this person, essentially, because, you know, when somebody's like, I'm suicidal, the reaction is, they need to be stopped or something like that as well. At the end of the day, we can't control somebody's decisions that they're going to make or anything like that. So it's more about best help and best care. We probably somewhat anecdotally, but in the lived experience workforce, we hear a lot about hospital systems being quite a traumatic place to go when somebody's suicidal. And from my own experiences as well, that is probably even more intensified in some autistic people as well. With the emergency room is not a particularly pleasant place to go to, and when you're in high distress. So there are going to be situations that are essentially an emergency as well. And we do need to take somebody to the hospital, but there's ways that we can try and navigate that and give the person decisions to make along the way still. So, if you're calling an ambulance for somebody, you can say, or like even a step before that, let's say, do you want me to drive you to the hospital? Do you want to go in an ambulance? Like, you're giving these options of like, we know we need to do this, but it's what would make it the best version of it for you in this moment. So if an ambulance comes, we can ask them on the phone to have their sirens and lights off for that whole trip. You know what I mean? Like that kind of, there's these little things that can help somebody, hopefully that, like the actual going to hospital or wherever it may be and getting the help that they need is not adding to the stress as much as possible. But yeah, there's definitely situations where the ED might be the place to go. We're kind of just saying, when somebody comes to you and they're like, I'm feeling suicidal, if you go, well, I'm calling 000, you've kind of brushed them off, and like, it's not validating of their feelings and what they're going through in that time. Just take 5 minutes even and just sit there and hear what they have to say first. And then you can still go.
So you've skipped the steps is what you're saying.
Pretty much.
So you skip. So
yeah.
So what are the steps in basic terms? Okay, so you're saying you validate them, you hear them.
Yeah.
And then what do you do? You ask them why you feel like.
Yeah. So yeah.
Why you feel like that? What would?
Yeah, I think it's really good idea to be really curious about their experiences. Like, we've heard examples of. I think this was an example from Lifeline. Like, a question that they asked people who were calling up Lifeline was, what would it mean or what would it feel like for you to take your own life? And essentially in that question, they're saying, what's going on for you now you're finding so difficult you want to take your life? And what would taking your life actually bring you? Is it relief? Is it these, there's a whole bunch of things that could come up there. So I think that kind of curiosity is a really good thing to hit on when you're kind of... having a conversation around suicide. Like active listening essentially is what it's called. Like,
rather than judgment.
Yeah, judgment or even trying to solve or fix anything in that moment.
But I'm autistic, that's what I do, mate.
I know. Yeah, it's a challenge.
How do you navigate that when your brain says fix things?
Yeah.
It must be hard to navigate.
I think one good tip I'd have, actually, because it is different for everybody. Some people actually want advice as well. They don't know what to do. They might be like, I just need somebody to tell me what I should do in this situation. But a good way to distinguish this, I think, is essentially just at the start of a conversation, just ask, do you want advice or do you want me just to listen? Like, give them that option of like, what do you need from this conversation? I think is a really, a nice way to go about it. And again, gives them a choice of what kind of support they might need. But yeah, I find it really challenging to not jump in and fix everything and do all of that.
Yeah,
but
you have to ask my wife about that.
yeah.
But can I ask you quickly? So from the medical profession, we take it in good faith. They're trying to learn and evolve. So from your point of view, how did that make you feel? What are your lived experiences of dealing with, say, a hospital or an ED or doctors? What did they do wrong? How did that make you feel? And how can we kind of improve that experience?
Yeah, I think it's a difficult one because, I'm working in the mental health sector. There is a bit of I wouldn't say divide, but there's tension with this new lived experience workforce coming in and the clinical models that already exist. Like, there's a bit of butting heads. There's still some stuff to work out there, how we all work and exist together. And I think it's...
On what? What are you butting heads? What are you actually butting heads?
Oh,
I love the tension. This is great. What's the issue between the lived experience and the clinical stuff?
I just imagine it's hard to hear that, because a lot of lived experience people coming in and saying these medical systems actually caused me harm. And I think a lot of clinicians and people working in their systems have really good intentions and they're really great caring people, and they got into that work for a reason, that they care and they want to help. Like a lot of them. There's obviously examples.
But they were taught out of a textbook 50 years old.
Exactly. Yeah, so that's the problem.
You're a psych patient, go straight to the psych ward.
Yeah.
This is the issue.
Yeah, so we're coming in and saying this all needs to be looked at. And I think there's a thing of saying, what you're doing doesn't work or something like that, which might be true, but it's not a personal attack. I think is the issue that's maybe felt sometimes, is that it's really this systemic failure, essentially, of these mental health systems and hospital systems as well, because they're a part of it, whether they kind of want to be or not. They are a port of call for people who are in high distress. Yeah, I think the tension's kind of around that, but I think that all will be worked out, because at the end of the day, everybody has the same goal of trying to help people and, you know, be a good mental health sector, essentially. I think a real problem I see is that there's such a there's these distinctive streams of disability and mental health. And I think the mental health sector needs to do a better job of taking responsibility for autistic people's emotional well-being and that kind of stuff as well. I think often we're put into the disabled camp, and that's all over here, and that's very separate. You get your funding, you get your whatever over here. Whereas I think we're hearing a lot about autistic people going to mental health services, and again, that being quite a challenging experience, whether that's sensory issues, not being understood or accepted, and all that kind of thing. And also just the different presentations, you know, like autistic people who are suicidal might not be bawling their eyes out or anything like that. Like, it might be how I'm talking now, and I just go, I'm suicidal. And people are like, well, you don't really seem that way, you know? So I think there's...
it's atypical. It's atypical.
Yeah.
It's like when I explained to you earlier how I feel in most days. It was pretty matter of fact. It's
yeah,
true. It's
yeah,
legitimate.
yeah.
You know, honestly, that this is an issue, right? We can have a lot of atypical responses. I mean, for goodness sakes, when I got pneumonia, I had atypical pneumonia. It's like, you can't write this stuff. It's comic. It's comic genius stuff. It's like, yeah, you've got pneumonia, my friend, but it's atypical.
Yeah.
So that sounds about right.
Yeah.
I mean, it's seriously. But you can imagine, and this is the problem, right? Because you present so differently,
Yeah.
and therefore it's harder to not only, I guess, express what you're trying to express, but also for that to be processed and conveyed back to you. Because really the system works on, you say something, they kind of try to say it back like that's what they heard, and then they try to work it out, right? But there's no meeting. It's complete disconnect.
Yep.
And I can imagine that's one of the big issues. And I'm certain the Senate report that came out in 2022, then they decided it was so bad, we have to do like an autism kind of committee thing. And, you know, like we have to, the Senate report was so bad, we need an autism campaign. Like, I think they call it an autism strategy, basically.
Yeah.
And, you know, one of the main things was mental health services. They need to actually reinvent the wheel here, because the mental health services weren't fit for purpose, you know, weren't right for the autistic community. And that's one of the main issues in the report. Now, this is, by the way, a report that came out in 2022, which said nothing but horrific things for the life outcomes of autistic Australians. Yeah. Yet in 2024, we're still going through a consultation period of getting a strategy, which presumably is not even leading towards the actual action we need. But you're absolutely right. There needs to be a clear separation here. This is something that needs to be addressed and evolved, and we need to have, you know, mental health services, providers, you know, resources that are actually designed fit for purpose for neurodivergent people, because they're not working in a standard system.
Definitely. And I think a great way to get that happening is to have designated lived experience roles for autistic people within mental health sectors, which it's happening a tiny little bit. I'm starting to see a little bit of it happening, but generally it's not there at all. And I think that would be just a really good first step of like, let's get some people in designated roles who have that experience and that understanding, and we can see what happens next. But I think, there's just little things that can be done that are really quite simple, I think. But I think, you know, it really needs to start with the acknowledgement of, you know, the research and all these policymakers and things, that suicide and mental health is, you know, really prevalent, let's say, within the autistic and neurodivergent communities as well.
Obviously, you know, we know that autistic people are different. They need different services. You know, they have different experiences. They live different lives. And you've talked about the experience we have in life. You know, these things that can trigger us can contribute to mental health conditions. From your own experiences, your own thoughts, your own research. You know, What else? What else am I missed here? What are the things that can help, that can add to a neurodivergence mental load?
For me, doing all this research and finding some things that I was looking at, I think there's maybe still a bit of a myth or stigma that autistic people are not driven by, like, there's no social motivation, let's say, is probably the term I came across a lot. There's this lack of social motivation, they're happier by themselves, all this kind of stuff. And research is now saying, which is, I think is just, everybody knows this already who is autistic, but we do need these meaningful connections in our life still. Social situations might be challenging or it might be a struggle or whatever, but there's still a need for connection and that kind of thing with other people, essentially. We're still social beings, that need, that need to belong and love and all this kind of stuff. There's research that's saying, the levels of loneliness, which is a major precursor for suicidality. Loneliness is a bit of a, again, incredibly prevalent and really intense in autistic and neurodivergent generally communities, I think. I think, again, just breaking down a little bit of that stigma and those myths around what autistic people need and want. Like, because I might go out for a few hours and then I might need a few hours at home by myself. But I'm choosing to go and rest after that kind of thing. Like, I needed both of those equally, I guess. I needed to go and connect, and then I needed to go and, go and relax in that way. So I think, again, it's that acceptance and understanding that, Jesse might come to something and then he might, leave earlier than everybody else. But that's still me filling up my cup and getting that connection and things that I need. So I think for a lot of autistic people, there's that misconception that they just don't need that. And I think that prevalence of loneliness is really contributing to the high rates of suicide as well.
It's mistaking, isn't it? I think for autistic people, it's mistaking a challenge in connecting with connection.
Exactly. Yeah,
this is the difference, right? So autistic people get this wrong. Autistic people don't have an issue with connection. In fact, we love connection with the right people. We will game with them or talk with them for hours, right? It's how we do it. Maybe it's on messaging, right? Maybe it's on platforms. Maybe it's while gaming, whatever it is. The issue is it's in the actual connecting with people that we struggle.
Yeah.
So the idea that means autistic people don't like connections and therefore maybe are being starved of them by their parents or carers or partners or whatever, or are starving themselves, can definitely contribute to poor mental health outcomes. And I think this is what's really important. People need to understand that. We thrive, in fact, on good quality connections.
Yeah.
The issue is the trouble we have in the actual connecting.
Yeah, and that's right. And then that, we always talk about in suicide prevention, having a person that you can go and talk to. And it's a struggle for a lot of people to identify who that is as well, particularly when you're having poor experiences with medical professionals and things. So again, you might only find that, that one person, but that one person is going to make a huge difference in your, in the feeling of loneliness and the feeling of connection that you get on the other side of that coin. I think that's really important. But that's obviously a two-way street as well. And that's where the acceptance and understanding and all of this, that the neurotypical people and all of this and the families and carers and everybody, like, that's the work, I guess, that we're advocating or asking to be done. We want to connect with you. It's a challenge for us, though. If you could do anything to make it easier, that would be really great. Like, that's kind of what I see the point of that advocacy is, essentially. Because, it's definitely can be a really isolating, difficult experience on a day-to-day level. So I think any little things that we can do to alleviate that and then connect with people is going to, hopefully, it's going to be a life-saving tool as well.
I 100% agree. Look, I think it's a great way to, it's a great point to end on, because what we're basically saying is to parents, to carers, to support workers, to friends, to partners, to family, you don't understand the sheer power of just helping enable a connection. Enabling that connection, finding, your child connects with someone or your partner, or, allowing and enabling a connection. You don't realise the sheer power of that. I think I'm glad that we got that out there. because people need to know that.
Yeah, I think that's a really lovely place to end it.
Hey, Jesse, it's been so great. I was just a really fascinating, eye-opening conversation, and I've just really enjoyed it. So thank you so much for being so generous and open. I appreciate it.
Thanks, Orion. And again, thanks for doing what you do as well. It was a really great resource and learning experience when I was going through all my diagnosis and everything as well. And really appreciate what you do.
If you want even more on the topic of mental health conditions and their connection to autism, I've got just that video for you. You're welcome to check out my video, The Connection Between Autism and Mental Health.